Does it?
Texas Tech University Health Science Center School of Medicine in Lubbock, Texas. We've had the privilege, Dr. Stephanie McClure, Ms. Ann Lawrence, and Dr. Paul Ramis, who were here yesterday, to be hosted by Dr. Michelle Saunders and the Geriatric Education Center of UTHSCSA. We are so grateful at your hospitality, at the types of things that are going on here. We're struck at the synergy and the energy that we see in real time. Paul Ramis is the Executive Director of the Garrison Institute on Aging of Texas Tech University Health Science Center, which might be parallel to the Barshop Institute, this institution. Ms. Ann Lawrence is the Educational Director for the Garrison Institute on Aging, and again, I'm at Texas Tech Lubbock campus. However, we have actually 4 different campuses in the Texas Tech University Health Science Center, 3 under the Texas Tech University Health Science Center School of Medicine. Another campus is Lubbock, Amarillo, and Midland, Odessa. Dr. Stephanie McClure is an alumna of East Tennessee State University, and there also she attended medical school and completed internal medicine training chief residency. She's a board certified in internal medicine, geriatric medicine, a fellow of the American College of Physicians, formerly our associate dean for faculty development, Merrick Myers endowed chair of geriatric medicine at TTUHSC in Amarillo, the center director for the Center of Excellence in Geriatric Scholarship and training and faculty development, and my colleague visiting here with you today. I invite Dr. McClure. Her topic will be approach to the older patient, osteoporosis and osteonecrosis of the jaw. I give you Dr. McClure. Thank you all.
Thank you. Thank you, Dr. Bertino. Thank you. Yes, that's. Remind me to pay you later. Well, I appreciate Dr. Saunders invited me to be here, and I wanted to talk a little bit about osteoporosis and osteonecrosis of the jaw and an approach to the older adult, because this is a health literacy slot, and so I wanted to talk a little bit more about that as to how we can help our patients. First, before we go further, I present a little cartoon. It's a mouse with a head caught in a trap. And the receptionist says, well, you must clearly explain your problem. And so, although it's quite obvious what the problem may be, when you're dealing with other folks, especially with looking at health literacy, it may not be as obvious as it seems, for that particular patient. And so just wanted to show you that little cartoon there. And I would like to just get an idea as to who all is here. Does everyone have a keypad? Here you go. There you go. Yes. When you respond, it should turn green briefly and then disappear. And so I just want to get the audience demographics here. You'll press A if you're a geriatric fellow, B if you're a geriatrician, C a gerontologist, D if you're in the dental profession, E if you're a resident, F if you're a student, or G if none of the above.
This is how we do it.
And feel free to dance. So we have 11 responses in. Do we have 11 people that have signed in? So we have 11 people that responded.
Here come more.
Oh boy. So well, like the majority that are here are residents, are learners, and we have a few geriatricians here as well, but otherwise pretty well distributed. And we do have look like some dental folks here as well. I guess they're not. That's not you and.
That's two of us. That's good.
Okay.
She's
Keypads, anyone? Keypad for you. Did I miss anyone? Anyone have a keypad? Okay. The next question for you. Do you perform an oral exam prior to prescribing a bisphosphonate? Press yes if you do, or number 1, 2 if no, 3 if it's not applicable to you. 15 people to sign in. And the majority of the folks here do not perform an oral exam. And then hopefully with this presentation you'll be able to understand the importance of doing that before prescribing a bisphosphonate. And let me just remind you, your responses are anonymous. There's no way that I know who and how is responding. So, well, let me back up then. Are you familiar with the term bisphosphonate-related osteonecrosis of the jaw, which is otherwise called BRONJ, or just in general osteonecrosis of the jaw? Press A if you do, if you are familiar, or B if not. All right, we have 7 people to register in. And great, the majority of the folks here are familiar with osteonecrosis of the jaw. Well, do you currently advise patients of this risk? Okay. Wow, it's equally
Did you plan that?
I couldn't plan that any better. Well, hopefully by the end of the presentation, everyone will understand of the importance to do so. So since this is a health literacy slot, I hope that by the end of the presentation that you all will be able to teach patients to understand that there is a benefit in management and prevention of osteoporosis, and that everyone will be able to appropriately discuss that risk of O and J if we do decide to use a bisphosphonate as the therapy. And also of importance, once you leave here, I hope that those who have not collaborated with the dental providers in the community will do so if we're going to prescribe bisphosphonates. So why is this topic important? So a question for you. What is the 1-year mortality for a 60-year-old woman who sustains a hip fracture? Press A if it's less than 1%, B if it's 5%, C if it's 20%, or D if you think it's 40%. And you have 15 seconds. All right. Okay, the majority think it is 20%. Any thoughts? Okay. Well, the correct answer is 20%. So that's pretty significant. So if you have someone that does sustain a hip fracture, there's a high likelihood that that person would die. Does anyone know or have any thoughts as what would be the primary reason for death within 1 year?
Pneumonia.
Yes, pneumonia is one.
Pulmonary embolism.
Okay, pulmonary embolism is number one. Number one reason why a woman with a hip fracture would die. So what percent of women do not regain their pre-morbid condition after a hip fracture? Press A if it's less than 1%, B if it's 5%, C if 10%, D if 20%, or E if 50%. Okay, we have 17 people, which I think that's everyone. And the majority of the group think it is E, 50%. Oh, come on in.
Sorry about that.
That's all right. We were waiting on you.
No, I'm fine.
And here's your keypad.
Wonderful, thank you.
And the answer is indeed 50%. So you can see how this is, how this is significant. So about half the women that do sustain a hip fracture never regain her pre-morbid condition. So, well, what about men? We talked a lot about men, women. Oh, men. Is this a true or a false statement that men have better outcomes after a fragility hip fracture? And the majority of the group felt like that's a false statement, and indeed that is false. And fortunately, the new National Osteoporosis Foundation guidelines have included men within the guidelines on management of osteoporosis, whereas the previous guidelines were all focused on women. But we do know that men are at risk for osteoporosis and fragility fractures, and that their outcome is actually worse when compared to women. So, if you're still asking yourself why is this topic important, just to summarize, osteoporosis is a major cause of morbidity and loss of functional dependence and institutionalization. 40% of those who do sustain a fracture will go into the nursing home, and out of that 40%, 25% will never leave the nursing home. 50%, as I mentioned earlier, will never regain their premorbid state, and that 20% will die within that first year. Again, why is this topic important? Well, I heard through the grapevine that if you don't tell them about it, then certainly some lawyer will. There's plenty of lawyers out there that are interested in making things right for the patient. And believe me, if you Google hip fracture or bisphosphonates, the first few things that you get that pull up are a different listing of law firms that are interested in helping the patient soothe. So perhaps you're wondering, well, why are we talking about osteonecrosis of the jaw? Maybe the majority of us here didn't hear anything about this during medical training, medical school. And is this a new disease? And here's a quote, an anonymous quote that says, if you think you've discovered a new disease, you probably haven't reviewed the literature thoroughly enough. And this quote is in Mark's book of Quintessence. He's a dentist. And indeed, if you look back in the literature 100 to 200 years ago, there are reports of what was called FACP jaw, in which a number of mine workers that worked in phosphorus, if they worked in the mines long enough and were exposed long enough, a number of folks were ending up with this deterioration in the jaw, which at that time was called FACP jaw. And you can see that he has this deformity here, which is necrosis of the jaw. And you can this picture doesn't depict very well, but you can imagine what a normal mandible looks like, and this certainly is not normal. So this disease was first described 100 to 200 years ago. So when we're talking to our patients, they may not understand what we're saying when we say osteonecrosis of the jaw, and probably dead jaw might be something, a terminology you might want to utilize. So how does bisphosphonates work? And they work by suppressing osteoclastic activity, and it works quite efficiently in areas in which there's rapid turnover of bone. And those sites tend to be the growth plates, the mandible, and the maxilla, as well as tumor sites or bone graft sites. As you know, with osteoporosis, there is significant bone resorption. And what happens with using bisphosphonates, it increases the bone mineral density, and it actually helps moderate the imbalance of that bone resorption in osteoporosis. And here's a diagram depicting what occurs when a person does take bisphosphonates. It gets laden into the bone. This is representing bone down here, and this is an osteoclast. So the osteoclast resorbs the bone, but if it's indoctrinated with the bisphosphonate is included inside the osteoclast, and this will cause the osteoclast to actually die off. And so the bone actually for the most part remains intact. So when a person is given bisphosphonate, it generally has a half-life of 10 years. And that's when given orally. So it not only interferes with bone remodeling, but it also affects angiogenesis as well. And so wound healing is impaired in those areas. Okay. Does anyone need a keypad? Or okay. Okay. Another question for you. Which statement, as of today, you know, because this is a rapidly growing literature regarding this disease. As of today, which statement is false? Press A if there are ways to minimize O and J risk, but there's not any way to completely eliminate that already low risk. The prevention includes good oral hygiene with regular dental care. Or C, the risk of dying from fracture of the hip or thoracic spine is higher than developing O and J. Or D, a woman's lifetime fragility risk is 10%. So which one is not true? All right, the polls are closed. And we have a good distribution of answers, but the majority felt that D. So let's just go through here. There are ways to minimize O and J risk, which is true, but not eliminate the already low risk. That is a correct statement. So no matter what we do as of today, it doesn't seem to completely eliminate the risk, but there are ways to minimize that risk, such as good dental hygiene. So that would make B being correct as well. Some folks thought that C was false. The risk of dying from fracture of the hip or thoracic spine is higher than developing O and J. That actually is a true statement. We talked about dying from hip fractures, that there was a 20% risk, but that same risk also applies for thoracic fractures as well. So there's a 20% risk of dying from thoracic fractures, and as you said, pneumonia actually is the #1 reason for death in thoracic fracture. So the answer is D. And what is the correct answer? What do you think that the woman's lifetime risk is?
%.
25, 30, actually 40%. And this is a very serious disease. So a woman's lifetime fragility risk is 40% over her lifetime. And I show you this graph here to further depict the seriousness of osteoporosis. This graph shows you the annual incidence of osteoporosis, heart attack, stroke, and breast cancer. And if you look at the first bar, and in your handout, there is an error. I think it says 1,500,000. It should be 1,200,000. The number of osteoporotic fractures per year is 1.2 million, which is more than the top three conditions, heart attack, stroke, and breast cancer combined. So knowing if a woman does sustain osteoporosis, a fracture from that, and knowing that she has a high risk of dying, you can see how this is quite significant. Another question, as of today, which statement is true? Evidence demonstrates that bisphosphonate should be avoided unless we're using it for cancer. B, oral bisphosphonates have the same rate of O and J as IV therapy. Or C, telepeptide or otherwise CTX levels of less than 150 is a good indicator of low risk of developing O and J. Or D, that the O and J risk is estimated at 0.7 per 100. Okay, did we lose one? All right. The majority of the group here felt that D is the correct answer, and in fact that is the case. The risk for ONJ is extremely rare as far as we know it as of today, which is 0.7 per 100,000 person years. So going back at the top, there is no evidence to demonstrate that it should be avoided. Strong evidence to show that bisphosphonates help with bone density and reduce the risk of fragility fractures. B, oral bisphosphonates have the same rate of ONJ as IV, which is false. When bisphosphonates are given IV, it's a more you're delivering a higher concentration of bisphosphonate, and accumulation is much more rapid. So that's a false statement. And CTX. CTX, actually, we may find out in the future that CTX is a good indicator for low risk, but we actually want that level to be greater than 150 as a predictor. Dr. Marks actually suggests that we follow CTX levels, but at the current time there's no strong evidence to show that that's of benefit. This is a graph just showing and demonstrating the different bisphosphonates there are on the market, and the ones that increase the risk of ONJ are the ones that contain nitrogen, and those are the amino bisphosphonates, which is the top 5 medications here. And we use all of these 4, all of them have been approved by the FDA to use with osteoporosis except for Zometa, and Aridia is actually used in Europe. There's Fosamax, Boniva, Actimel, and Reclass. So the case definition of ONJ, particularly bisphosphonate-related ONJ, is that person obviously is exposed to bisphosphonate at some point in time, and there's exposed bone in the maxillofacial region that's persistent more than 8 weeks, so it's an unhealing area of bone, and there's no history of radiation therapy to the jaws. The mechanism of ONJ is unknown, but it's felt to be related to the bone physiology as far as wound healing and bone remodeling. And it's also suspected there might be some genetic variations in the drug metabolism. As if you look at the folks that develop ONJ, it's suspected that it's related to poor dental hygiene. But a large number, millions of people are on bisphosphonates, and millions of people get dental procedures performed, including extractions. So why is it that only a very few, a rare number of people actually develop osteonecrosis of the jaw? So we're talking about the jaw. Why aren't these folks developing osteonecrosis of the hip? We hear that a lot when using steroids. So why the jaws? And it's suspected because of the high degree of bone turnover in the jaw. In fact, in the upper mandible, the rate of bone turnover is 10 times the rate of that compared to the tibia. And as you move inferiorly along the mandible, that rate, although it's still elevated, it does decrease. But you can see here in the the superior portion of the mandible that this is where the teeth are extracted, which, as I had mentioned, increases that risk of ONJ. So the current known risk factors for ONJ include some history of dental alveolar trauma, so that includes dental extractions, a history of inflammatory dental disease, so we're talking about gingivitis. The duration of bisphosphonate exposure. We know that people that have been on bisphosphonates greater than 3 years seem to be at higher risk than someone that has only been on it for 1 year. The type of bisphosphonate, so oral versus IV. and if there's concomitant long-term steroid use, that puts a person at high risk. So I had mentioned in the previous slide about the risk of ONJ. At the current time is estimated to be 0.7 per 100,000 person years, and that's derived by taking the number of reported cases, and albeit that's not confirmed, not the confirmed cases by oral surgeons or other dental providers, but the actual number of reported cases, dividing that by the number of eliginate pills that are actually been prescribed on the market, and that was converted to patient years. So keep in mind that that may actually be an underestimate, because we're talking about people that have actually been reported. How many of your Medicare patients actually go to the dentist? But, you know, Medicare doesn't cover dental. So there's a number of folks that probably never seen a dentist in their entire lives. And so I'm sure there's a lot of cases out there that we just don't know about. This is a photograph showing you an area of risk of developing osteonecrosis. Does anyone know what these are? Right, a torus or tori. So these areas are covered by a thin layer of mucosa, and so that if that gets nicked and the person is on a bisphosphonate, then they're knowing what we do know at the current time, if they are on a bisphosphonate, then that might put them at risk. So when we're talking to our patients, we do need to do a good oral exam. And what you're looking for isn't any ulceration along the mucosa with any exposed bone. And I've only seen one case of this, which was very early disease, in which it was in the maxilla, actually, on the hard palate. And there was I could see the bone. There was just no mucosa over the bone, and the patient was totally asymptomatic. But the patient, if the patient is symptomatic, they may complain of pain or swelling in the affected area. The tooth will be in that area, may be mobile because of the necrosis of that area, and they may have infection with or without the pus being present. And oftentimes it's described as kind of a numbness or a heavy sensation in the jaw. So here's some more pictures of osteonecrosis of the jaw that's related to oral bisphosphonates. This on the right side, this is where a tooth has been extracted, and this is all necrosis. Here, along the lingular side of the mandible, we see that this also demonstrating necrosis. This patient here had received IV bisphosphonates, such as that we give, for persons with cancer, and it's showing a fistula tract, and so there's actual involvement of the mandible, and so it can be pretty significant and debilitating. So it can be small, such as this area around the tooth. All this here is demonstrating necrosis, or it can be large and painful and very disfiguring. Here, all this is necrosis, and you can't see it very well, but there's also necrosis over it on the left side of that picture. This is a person that has osteonecrosis of the jaw just from simple dental extraction. So this is an area of necrosis. Believe me, when our patients are going out and they are seeing a dentist, a lot of the dentists are keen on ONJ, and they're asking their patients, "Are you on a bisphosphonate? Have you noticed any changes in your mouth or jaws? Have you had any jaw or tooth pain? Have you noticed any sores and foul smelling, swelling, or discharge in your mouth?" So these should be the same questions that we should be asking our patients. And if we don't forewarn our patients, then they're going to be very angry at you, because believe me, the dentist is going to say, well, you shouldn't be, well, a number of dentists will say you shouldn't be on this medication. And so that's another reason why it's important to talk to our patients and to collaborate with the dentist, advise them, give them a heads up that a patient is coming to see them, and you want their advice on whether or not if they would be a good candidate for bisphosphonate. So when we advise our patients, we can advise them that elective dental surgery is not contraindicated, and that we can use CTX to monitor as to whether or not if it's a good time to go on to dental surgery, although again, as I mentioned, there's no strong evidence to currently support that. So, but I'm advising you of this today because the dental community is pretty much using that guideline. They're looking at the CTX levels, or at least encouraging patients to go back to their medical doctor to get that level done. And if the patient has been on it greater than 3 years, then you can advise them of that possible increased risk. If they've only been on it for a year, it's unlikely that they would develop ONJ. And if they are on steroids, you can advise them that steroids in itself has its own risk. Again, as you weigh in the risk and benefits, you want to be sure to remind the patient that the risk of having significant morbidity or mortality from hip fracture is significant compared to ONJ, and that the incidence of fragility fracture is greater than heart disease, breast cancer, and stroke combined. We need to discuss the options of osteoporosis management, including that there are other things out there that we can utilize, including the SERMs. However, at the current time, bisphosphonates are pretty much the best that we have for increasing bone mineral density and reducing fragility fractures. And we also want to be sure to advise the patient of the need for a comprehensive oral examination. ONJ is a rare risk as far as we know it today. There are ways to eliminate there's not a way to eliminate the risk, but there are ways to minimize that risk by having good dental hygiene. As you know, if you're working with cancer patients, we send them to the dentist before radiation treatment because of this particular risk. So this is not any different than how we counsel our cancer patients. And again, a CTX may be a good guideline for management. So as you can see, collaboration between medical and dental providers really is essential because we don't want our patients going out and having the dentist be the one to explain that risk when we were the ones that actually prescribed the medicine. So as responsible providers, we need to counsel the patient regarding those risks, although it's rare. But the last thing you want is a patient being upset with you for not advising them of that risk of osteonecrosis in the jaw. And again, communication is paramount. So before they head out the door, you want to check with them to make sure that they really understand what you've told them. And so, in general, I would ask, tell me, what is your understanding of the problem? What are the issues that we addressed today and will be working on? And as you go home, what types of things will you be working on? What will you be doing? And what is your understanding of when you should come back? And what is your homework assignment in the interim? It always makes good practice to advise the patient if you have any questions or concern when you get home to please contact me. Other actions is you feeding them a lot of information, and does anyone know how much of that information the patient actually remembers. You know, as an educator, as a teacher,
10%.
right, 10 to 20%, exactly. So it would be helpful if we write out the instructions for the patient, the information, or in addition, provide them handouts. I did want to talk a little bit about handouts as part of this health literacy slide, and I don't know how much you've received on developing handouts, but I have here, if you're going to make your own handouts, that it's a good idea when you're working with older adults that you use the typeface that's serif. And serif is the type that the letters has some type of curve or tail on the end. So if you look at times, the T at the top and the bottom, it kind of has a line that draws your eyes across across the word. Like if you look at that A, the A brings you to the end. The same thing with Georgia. And it's recommended that we not use a straight line type, which is the sans serif, such as the Arial or Tahoma. In your, before I go to the handouts that you have, also note when you type your handout, so that it should be anywhere from 12 point to 14 points in size, and allow for white space. So the more white space that you have, the better, rather than trying to cram as much written information on one page. And if you see this, do not use all capital letters. This is a little bit harder to read than the rest of the information on the slide. So it is recommended not to use all caps, and to double space and keep normal spacing between the letters. I have in your handout on how to check your handout to see what reading level that it may be. So if you're processing your handout on Microsoft Word, you can determine what that reading level is. Is everyone familiar on how to do that? Okay. In your handouts on the back, the last several pages, you'll have a handout that's labeled. Do you have an extra handout?
No, no.
Okay, thank you. This, it says osteoporosis or weak bones. Look at that and tell me what grade level you think this might be.
Fourth grade.
Who said it? That's pretty close. 4th grade. Would you like to share as to how you came up with that?
It's just very easy to read, very easy to understand. But some of the words, like kidney and steroids, some of them that's what makes me think it's higher than 2nd or 3rd grade. But
okay. And when we do our handouts, a good target is to get it around 9th grade level, so 8th or 9th grade level. And the way to determine what the reading level is, since I've already been through this document, it will actually automatically tell me here in a minute, but on a document that has not been proofread yet, you will want to go down to Word options. If you have this particular...
that's 07.
07. Mm-hmm. So Word options. And in your handout, I actually have the older version, the 05, I believe. And then go to Proofing on the left there. And here you want to make sure that check grammar with spelling is checked. Make sure that's checked. And then go down to show readability statistics. That's what's going to tell you. So make sure that that's checked.
No?
Okay, and then hit OK. And then go back up and do this spell check and the grammar check. So we're going to go to review, and then spelling and grammar. And again, since I've already reviewed this, it didn't go. It's telling me that the spelling and grammar has already been checked and complete. But when you hit OK, you'll get this table here that says readability statistics. Can everyone? I hope you can see that. But it'll tell you the number of words that are in your document, number of paragraphs and sentences, the words per sentence. So the less words, the easier it is to read. Passive sentences. So this document has no passive sentences. Everything is in the active form. So that makes it very simple reading. And if you go down to the Flesh Kincaid grade level, this is a reading level of third grade. Okay, so you can do this on all your documents. No matter who your audience is, you can modify your handout to customize that to your audience. So this is relatively simple document to give older adults. But remember, a lot of our older adults, have not completed beyond third grade. So this would be an excellent document. So I'm going to get out of this. So that's an example. And let's see, get back over here. So if you're, surely there's not anyone in here that's is questioning why this topic is not why it's not important. And you may be thinking, oh, well, this is too much to remember. I just want to treat patients with osteoporosis. Well, unfortunately, the world is not like that. Not addressing the issue of osteoporosis can also lead to litigation as well. Has anyone heard of the law firm of Dewey, Cheatham, and Howe? Or in other words, Dewey, Cheatham, and Howe. So you don't want to encounter these three stooges. And there certainly are people out there that are willing to work on patients' behalf to set things right. Some final questions for you. Will you as a practitioner, will you do any of the following? A, will you counsel patients regarding OMJ risk? B, refer to a dentist if bisphosphonates are considered. C, if you'll do both of those, or D, if neither. All right, the majority would do both of those.
Just a question. I mean, many patients, actually, as nice as that sounds, don't actually have access to them. So you can refer them, but that doesn't mean they're actually going to get it.
Exactly. And in our community, we work with the dental community with a hospital district has gotten some funding for indigent care to try to get folks in, and we're still working on trying to get access, to older adults that are otherwise medically indigent. They have Medicare but don't have dental insurance, and that is a challenge. And one last question. If you do decide to refer to a dentist, how will you most likely help your patient? Will you personally call the dentist? Will you send a letter to the dentist? Will you try to meet with the dentist, or have some other type of personalized contact? Will there be a combination of any of those three? Or E, you'll do nothing else and hope that the dentist doesn't know about OMJ. Okay. All right. The majority had indicated they'd do a combination of the above, and unfortunately we don't have any smarty pants in here that said they'd do nothing. And I appreciate you all inviting me here today, and I hope that that these key points that I presented will help you in your own practice. Before I close, I did want to, if you have not been, just a special thanks to my dentist partner who's helped me do research in the Panhandle. And we've actually developed a consensus statement for the Panhandle for dental providers and medical providers on how to approach using bisphosphonates for our community. And a number of those slides he had let me borrow for presentation today. So I wanted to give thanks to him. And for those who have not been up in the Panhandle, I just wanted to show you the wind turbines that are present on the landscape. And although you do have a sunrise here, I'm not sure that you have the flatness and all to truly appreciate the sunrise on the horizon. And in closing, this is a beautiful sunset in Amarillo, Texas. So I'm going to stop here. We're kind of out of time, but if you have questions, I'll be more than happy to answer.
Dr. McClure, could, just because you're visiting, I'd like for everybody just to quickly introduce themselves to you, if you don't mind, and we'll start with you and what your role is here.
I'm Sarah. I'm a pharmacy student.
Okay.
I'm Sharon Shearhart. I'm a Geriatrics clinical pharmacy specialist.
Oh, great.
I'm Jacob. I'm also a pharmacy student.
Okay.
And before you leave, you are?
I'm Alex Deperalta. I'm a dentist.
Dentist, all right.
And I've seen a lot of OMJ.
Have you?
Quite a bit.
Related to oral?
Related to IV bisphosphonates for multiple myeloma and things like that. It does happen. I've not seen any cases of oral.
I see. Yeah. Oh, thanks for coming.
Thank you.
For coming.
That was very nice.
Let's see, right here.
Ashley Lowry, Hospice and Palliative Medicine Fellow.
Okay.
Gerald Patel, Hospice Palliative Care Fellow.
Okay.
Chris Ramsey, internal medicine resident.
Rebecca Tapia, rehab resident.
Not Brad Pitt, but go ahead.
Tony Stark, rehab resident.
Okay.
Brian Chum, psychiatry resident.
Okay. Laura Charter, geriatrics faculty.
Mark Craig, geriatrics.
You'll meet him later.
Oh, great.
Sandy Bell, geriatric psychiatry fellow.
Oh, great.
Genius Patel, Palliative Fellow.
Okay.
Dr. Deborah Villarreal, geriatrics care staff.
I'll meet her as well.
Oh, okay.
And Rebecca Rotman, geriatrics clinical pharmacy specialist.
Okay, great. Thank you. Well, we had a very diverse group. Excellent. I appreciate you all being here, and I look forward to. We had Texas Tech. We had talked about the possibility of collaboration on a number of educational projects, and I look forward to coming back and having you all to come up to Amarillo or to Lubbock or even to Permian Basin where we are.
Thank you. Y'all be sure you sign in, and I need your evals back. Thank you.
Thank you.